we can go ahead and get started. Don't want to make everyone wait that's sitting on today. So first off, just want to introduce myself. My name is Phil Hamburger. I'm a risk advisor here at Ellerbrock-Norris. I'm stepping in for Elliot Bassett today, who was our previous MC on all of our previous roundtables. So if anyone would like to see me back after this one, just feel free to reach out, and I'll tell Elliot that his job has been replaced moving forward. So again, just want to mention some housekeeping items. The mute and unmute button is on the bottom of the screen. You'll find that. If you have any questions throughout the discussion, feel free to unmute and ask those. There's also a chat box located at the bottom right of the screen. Feel free to type in any questions throughout the conversation. We'll be monitoring that throughout. So first off, wanted to introduce Seth Denson. He is our Chief Healthcare Strategist. He's going to be leading the discussion today. Seth is a business and market analyst who is also the author of The Cure, which is an Amazon bestseller for a short period of time, but something we always like to mention. He's a regular contributor on a lot of major news outlets, and we're really excited to have him on today. So kind of to kick off, the topic of the roundtable today is going to be around plan designs. And our previous discussion, our previous roundtable that we held was around plan documents. And so we thought this next one was a good segment to kind of talk about plan designs. We understand that your plan design is very crucial, and sometimes it's overlooked at times. So the first quote, a good question I thought to kind of kick things off with was, Seth, I think a lot of the times many people, when they think of plan designs, they think of deductibles, co-insurance, co-pays, et cetera. But we understand that there's a lot more to it. Would you agree with that?
Yeah, Phil, great question. And I do agree. I think that a lot of times we have this box of plan design, so to speak, that we live in large part because that's what the insurance industry has put us in, right? So when we think about things, we think about deductibles, co-insurance, co-pays, out-of-pocket maximums. Are these things covered under the copay, or is it deductible co-insurance, right? All those kind of basic, we'll call them line level plan design things. But one of the things that we actually discussed, I think on the last roundtable when we were talking about the plan document, is the different levels and layers that go into a plan design. Whether that's, hey, can you have somebody go sit for 6 months off of the coast of Malibu at beaches for drug and alcohol abuse? That's going to be part of your plan document, but it's also outlined in your plan design. Deductibles, how do they really operate? Are they embedded? Are they aggregated? Are they structured in a way that they're resetting on a monthly basis or annual basis? Do they follow your calendar or plan year? There are literally dozens upon dozens of layers that go into creating a plan design that I think all too often employers just kind of look at it as surface level. And again, okay, that's fine. But the reality is that your plan design is really a critical tool to do two things: to drive employee perception, good or bad, and drive costs, good or bad. And there's this misnomer out there, this idea that raising the deductible saves the plan money. I can tell you emphatically, it does not. No matter how much the insurance industry wants you to think it does. That's called misdirection. They don't want you to recognize that lower deductibles actually can save you money, so long as they are structured appropriately within the network plan. And what I mean by that is, you don't want to go for a free-for-all where you lower the deductible to next to nothing and say, okay, no deductibles, go and use and prosper. That's naive. That's like giving everybody a credit card and saying, go, we don't care. But if you say, hey, we're going to reduce the deductible or eliminate the deductible, and here are the key areas in which you can use the plan with no deductible, or maybe these certain things have deductibles, these don't, all of those things can be done. You, as an employer, have complete control over your plan design. so long as you have the right administrator that's willing to do that. And so I think, and what we'll obviously dive into more today, is there's really a blank sheet of paper that you can create a plan design off of. Almost any employer, actually, regardless of size, although we can get into some of that discussion. But don't always just take what it is that the insurance company gives you and say, this is what we've got to do, right? If we're in a tight labor market, you want to be able to get creative around specifically what's going on with your specific employee population. You want to recognize that one size rarely fits all. And then you want to also recognize that if you're adopting a plan design that the insurance company has given you, they're likely giving you the plan design that best benefits them. So keep that in mind as well.
Yeah, those are some great points, Seth. And you had mentioned a couple things in there. One of them was, it's not a one size fits all. And if any of you have heard or sat on any of the previous roundtables or been engaged in any conversations with us, we talk about that a lot. It's not a one size fits all when it comes to what plan design or what program is right for your organization. So you also mentioned something else in there, Seth, and I think that'd be a kind of a good segue. You'd mentioned, as far as can any employer, customize their own plan design. So can you kind of walk through that? Is there restrictions, or can any employer customize their own plan designs?
Yeah, if there are restrictions, they're typically found in two areas. One is if you're fully insured. Now, remember, if you've been a part of any of our, roundtable discussions, before, we've talked about the fact that there's really only two types of insurance financing mechanisms that are utilized today: fully insured and self-funded. I know that we hear partially self-funded, we hear level funded, we hear all this other crap, because that's really what it is. It's just a naming mechanism that an insurance company is given. But the technical answer is there's really only two types of financing mechanism: fully insured, which means I'm giving money to an insurance company for a set period of time. They're assuming all risk, and then in likely 12 months, they're going to assess what they spent and then appropriately set my premiums. That's fully insured. And in that world, Phil, yeah, you're going to have very little flexibility capabilities. And that's in large part because under fully insured plans, they are still governed by the state. So if you're in the state of Nebraska, if you're working with Blue Cross or Aetna or United Healthcare or one of these others, and you're in a fully insured platform, then they actually have to go to the state of Nebraska and file all plan designs. So it's not where you can come in and customize it, because it has to fit in whatever box they've created. The bigger you get, the more wide that box can be. But specifically, if you're fully insured, you're going to be constricted in what you can do. Now, again, if you've been part of our roundtable discussions before, you've heard me say that nobody's fully insured. Everybody's self-funded, whether you realize it or not. Whether you're paying that claim today or you're paying it tomorrow, trust me, you're paying it. And so if you're in a self-funded scenario, sky's the limit. You can do whatever you want. Now, you have to have an administrator that's willing to do it for you. And that's a critical piece here. So know that if you're in the self-funded world, and by the way, all self-funded plans in the United States, with the exception of a few major organizations like maybe Time Warner, or companies with hundreds of thousands of employees, all are considered partially self-funded, in large part because almost every one of these plans has what's called a reinsurance component. Now, understand what I just said there. Reinsurance, also known as stop loss, right? Why it's called reinsurance as opposed to insurance is because it's not actually insuring the claim. It's reinsuring you're paying that claim, right? So if you're self-funded, they're using your money to pay the claim. And if you have reinsurance, they're reimbursing the plan. So if you're in a level funded scenario, maybe with Cigna or Aetna or anything like that, Aetna's taking a bank account out in your name. They're paying all claims on your check stock, and they're using the reinsurance to reimburse that bank account. You may never see that happening, but trust me, they're following the letter of the law under ERISA, which means that if you are technically an ERISA self-funded plan, you must be paying the claim. The reinsurance will reimburse that claim. And so why that's important to note is that you have control when you're paying the claims. So long as you comply with the Affordable Care Act and some of the mandates there and all of that, you can quite literally control the plan design. The critical piece, if you're self-funded though, is you have to have an administrator that's willing to work with you on that. Most administrators are willing to do that if you're outside of one of their bundled packages. So I mentioned a minute ago, Aetna, they have this AFA platform, right, that's pretty widely used throughout Nebraska. Probably not going to be able to customize much there. Cigna has their own level funded platform. United Healthcare has a group called All Savers, right? These are pre-canned structures, so you're not going to get a lot of flexibility there. But if you get outside of those, and by the way, those pre-canned structures are costing you money, just in case you're wondering. They're increasing the administrative cost. And I say a lot of times with those plans, there's exceptions to the rule, right? But oftentimes, heads they win and tails you lose. Because they're able to protect their back end while simultaneously creating more money and profit off of the administrative fee. But going back to, can anyone customize? Yeah, anybody can, so long as you can find the administrator to do it and you're willing to move into a self-funded platform.
Yeah, thanks for answering that, Seth. I think that was definitely an important thing to kind of hit on because, a lot of the times, I don't think people realize that they do have control over their plan design. So definitely wanted to get that kind of answered before we kind of move forward and dive into some other things here. Kind of the next question that I had are, what are some issues or challenges maybe that employers need to be ready to address when it comes to customizing a plan design?
Yeah, I mean, listen, that's a great question. And a couple of things. First of all, is recognize what I said at the very beginning, where you're creating a plan and a plan design can be a good or bad thing. So you want to always make sure that you're serving the purpose of what it is that you're trying to accomplish through the plan design. I oftentimes will tell employers, we'll tell them when we're working with them at Ellerbrock, don't go open-ended on anything. And what I mean by that is don't give a free for all unless you've just got money to burn. Because trust me, it will get burned. That's like going to the casino and slapping your credit card down and saying, let's have some fun, right? Because at the end of the day, the healthcare system will exploit as much as it can out of your plan. So you want to keep in mind, how can we protect the assets of the plan while simultaneously rendering a good benefit for the employees? So I always tell them a couple of things. First of all, you got to know who your employees are, right? What is the demographic structure of your employees? How many Gen Xers versus Gen Zers versus baby boomers do you have working for you? Because each of them is going to have a different need. Second, recognize, and this is something we've said a lot, that don't make the plan design the barrier of accessing the system. And that's in large part why I think we've seen this shift over the last 20 years, where insurance companies are encouraging employers to raise deductibles by means of saving money. It doesn't save money. It actually costs you more. And the reason is because if I could go get that MRI, I'm going to uncover what's going on and likely get it fixed before it becomes a major issue. Major issues cost more money than minor issues. I can buy a lot of MRIs for one spinal fusion surgery, right? I can buy a lot of physical therapy visits for a total knee replacement. I can buy a lot of dietary programs and things like that for insulin dependency. Again, and I'm not saying that we can solve for every one of those issues, but statistically, we've said this a number of times, 90% of costs is generated by 10% of your population. Said differently, 90% of all profit in the healthcare system is generated by 10% of your population. And the insurance companies and the healthcare systems know this. They can generate profit certainly off of an MRI, the way they've structured it. But if you structure it the appropriate way, you can limit that. But then you can also protect the long-term claim. So spending $500 today on an MRI to prevent an $80,000 claim a year from now, that's a pretty good decision, in my opinion. And so I think that's a lot of times the hurdle that people need to think about when they're trying to to think about creating plan designs. First is recognize who your employees are, what's going to motivate them. Second of all, recognize one size fits all, like we talked about. But then third, don't create a structure that's going to prohibit access to the system. Create a structure that's going to encourage access to the system, but in a protected way. So I'm going to give a couple examples, right? So first and foremost is almost every client that we work with at Ellerbrock has an insurance network, right? Now, within that insurance network is various pricing structures, especially if you're working with what we call a BUCA network, a Blue, United, Cigna, Aetna, Humana network. If you're using one of those five or even the Midlands Choice, there is a vast array of cost variance for the same procedures based on where, when, and how you're getting them done. So creating a plan design that can encourage good decision-making around where you get your procedures done can do two things. One, it can allow employees to gain access to the healthcare system without the burden of deductibles, coinsurances, and copays. So we're getting the treatments that we need done. And then second, it protects the overall assets of the plan. So when you're creating a plan, think about that. Don't think that we have to say, okay, well, we have a $2,000 deductible for the in-network. You can create tiered deductibles. You can create deductibles that say, hey, for the providers that we've identified have lower cost and equal or better quality, we're going to lower the deductible. And we can create tools within the plan to make sure that employees know where that is. For the providers that we've identified that have higher cost or lesser quality, we're going to raise the deductible to its highest levels. You can do that, right? And it's a way to manage cost while simultaneously improving the value of benefits. Because when you can go into an employee and say, hey, you need an MRI, we're going to make sure you get that MRI. You need that CT scan, we're going to make sure. You need that physical therapy, that chiropractic visit, blah, 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 all down the line. We want to make sure you get it. But much like Amazon does, we're going to make sure that you have options. And within those options is a lower cost option or a higher cost option. And it's completely up to you, employee, on which way you want to do that. Recognizing the vast majority of employees are going to take the lower cost option. They just are, especially if the quality metrics are in alignment. So that's part one. Part two is recognize you can use sticks, right? Again, if you're in a tight labor market, I don't encourage sticks. Right? People go work elsewhere. But you can certainly say, hey, we're not going to pay for this here. We'll pay for it there. We're going to structure a plan around affordability only and not give employees access to options. You can absolutely do that. So I think the biggest thing that employers make hurdles on is they don't think that out of the box, and they don't recognize who their employees are. Many employers that we talk to make benefit decisions based on their own ability. And what I mean by that is, if you have the CEO or CFO or a high wage earner making a decision on benefit plans, oftentimes they will make it based on how they perceive the plan, not necessarily how their employees will. And I think that's a big, big issue. Because, matter of fact, we were on the phone yesterday with a client who was adamant about lowering everybody's deductible, but charging them more, right? I want to lower the deductible from $3,000 to $1,000. This is what he said. And I'll just ask everybody to pay $50 more a month for it. But it's better for them to have the lower deductible. And I said, are you making that unilateral decision for them? Because what you've just told me is you're going to ask them to pay $600 more a year for a deductible that's $2,000 less, when out of your company of 150 employees, only 11 people hit the deductible anyway. Thought about that? Well, what we got down to it was he wanted a lower deductible. And he had a couple of employees he was wanting to recruit that he wanted to be able to show they had a lower deductible. And so where I'm going with that is you need to understand the buying methodologies of your employees. And I will all but make this guarantee, even though I don't typically do that. The majority of your employees care more about what's coming out of their paychecks than they do their deductible, coinsurances, and copays. Now, at the same time, I'm not saying they don't care about those things. And never, ever, ever use a consumer-driven high deductible plan as a cost-saving mechanism. I assure you, your employees don't think it that way, at least not for them. They're not good consumers. So all they're seeing is it's a cost shifting mechanism. It is putting the burden on them, taking it off of you, and what that will do to you in the long term, it will raise your claims because those employees aren't going to go get what they need done, and that's a problem.
Yeah, those are great points, Seth. We did have a question come in from Lori, and it looks like she's got to hop off. Actually, yep, she's still on here, so she got to hop off at 11. So I wanted to make sure we got this addressed before she hopped off. Her question was, with transparency starting to happen with provider pricing, what do you think will happen with reference-based pricing increasing in popularity / acceptance by providers or going away?
Yeah, I actually think that reference-based pricing will become less popular as a result of transparency laws. I think that hospitals will look for unique ways to restructure contracts. You know, and I don't know that reference-based pricing will be the long-term solution there. Now, again, I don't know if Lori, specifically, you've been on any of these roundtables. Many of you that have heard me say, I'm not opposed to reference-based pricing, but I like laser-focused reference-based pricing. In other words, I like looking at specific procedures and saying, how can we utilize pricing in Medicare to offset those costs, to set a plan design or plan document structure around how we're going to pay for end-stage renal disease or transplants or something of that sort. But and again, if I meet with a client who says, hey, Seth, I got to cut costs by 30% next year. I don't have an option. Great. Guess what we're going to do? We're going to reference-based price everything. So just to maybe clarify for those that don't know, reference-based pricing means that you're setting your reimbursement rates based on what Medicare would pay. So a typical reimbursement rate for reference-based pricing would be somewhere between is on the low end 120, 130% of Medicare to the high end 200, 300% of Medicare. Interestingly enough, in Nebraska specifically, reference-based pricing hasn't really taken off, and that's in large parts because the hospitals are rejecting it. So in large part, hospital systems have banded together and said, yeah, we're not doing that. And that's in large part because in Nebraska has one of the highest reference-based platform or pricing structures if you were comparing it to Medicare in the United States. I mean, where in a place like Texas, for example, specific parts of Texas, obviously it's a big state where I am, but in certain parts of Texas, you'll see the average Aetna, Blue Cross, United, Cigna network contract be somewhere around 200, maybe 225 or 250, even in some cases lower than that. If you're going to like the Valley in some areas of Texas, you may see it around 170. In Nebraska, the reference base is typically somewhere between 300 and 400% of Medicare. So, if you go all gung-ho and put this, hey, I'm going to go at 250% of Medicare and try to walk into CHI to get something done, they're probably going to let you walk right back out. They're not going to see you. So again, you want to make sure that you focus on those things. I think that hospitals, by and large, will utilize this new transparency law to rework the system. I think many won't comply, personally, Lori, as far as that question goes, because I think that the juice just isn't worth the squeeze. The fine for non-compliance is $300 a day. That's rounding error for most of these hospital systems. And so they'll just pay it. They'll just chalk it up. Now, the reason hospitals will comply has nothing to do with a penalty. It will have everything to do with a perception, right? So is it going to be perceived that I'm not complying with the law? And so they likely will, but they will still find a way to be as ambiguous as possible. But I don't know that reference-based pricing will take a foothold. I think it might go the opposite direction.
Yeah, thanks for that, Seth. And it's something that we definitely deal with, and we hear a lot from when talking to prospective clients. And as you mentioned, when it comes to saving money, it definitely is a good answer. But the noise that it can create in return, we know that it can create a lot of noise. So, yeah, thank you for answering that question. Kind of jumping back into what we were talking about before we kind of got into reference-based pricing. After kind of talking about some issues or challenges employers need to be ready to address, what would you say are some good things to be thinking about when employers are trying to determine what the best plan plan design is for their company.
Yeah. One thing is, and I'll kind of go back to something I said just a minute ago, recognize who your employees are, right? So we have to find a balance between employee perception and availability and access and cost. So the best information gathering tool that you have are your employees. Ask them. Ask them what they care about. Ask them what's mostly important to them. And you can adopt what I call the yellow brick road methodology when you're asking them. And what I mean by that is show them the way to Oz in your questions, right? Help them identify and recognize solutions in your questions. So, for example, if you said something like, hey, do you want us to be able, do you care more about going to the doctor that you want to go to or a lower deductible? Well, I mean, again, you're going to get a smattering of answers and they're going to be all over the map. Some are going to want, because they're thinking you're asking them, are you okay with me giving up my doctor? Many employees aren't going to want to do that, right? If you ask that same question, if we were able to provide you with access to multiple physicians with equal or better options or ratings and not charge you to go there, would you utilize them? Well, yeah, absolutely. Or said differently, hey, we're not going, if you had the option of using your existing doctor at a premium cost or a doctor that has equal or better credentials for a lower cost, would you be willing to make a change? Right? What they're doing now in their answer is telling you, okay, here's how to structure my plan. Here's how to tier my plan out, right? But get even more granular than that. And I always tell people, doctors specifically, don't go. That's the holy grail of relationship. So focus on the non-relationship things. Do you care about where you get your MRI? If I can get you an MRI for free, would you use it as opposed to one that you would have to be deductible coinsurance? If I get you an MRI for a fraction of the cost, or could you pay copay for imaging, CT scans, surgeries, things like that? Again, you're getting them to say yes in their questions so that you can come back in and create the plan design around it saying, yes, we're not removing access. We're just saying that this access, which is going to save the plan money, is going to be lower cost. And now they're thank you for it because they felt like they were part of making that decision. So again, you can utilize asking your employees to help guide you where you want to go. Second of all is recognize that there is no box that you have to stay in. And what I mean by that is we met with an employer recently who was saying that specifically they had a population of young supermen who really didn't care about insurance for them, but cared about insurance for their kids. So the recognizable follow-up conversation, well, what do you charge for kids to be on the plan? Oh, we don't pay for any dependent coverage. We just pay for the employee only. Why? Well, we have to pay for the employee only. No, you don't. You can create a plan where you pay for the employee only. Why not create a plan where you just cover the kids? Right? Where the employee can opt out, but the kid can take it. Who says you can't do that? Nobody. Now, you have to have an administrator that can do it and a reinsurance carrier that will write it. But guess what? I can throw a rock and hit 50 of them. There's a lot of options around administrators, and there's a lot of options around reinsurance carriers. Kids are cheap, by the way. From a claims perspective, rarely do they cost you a lot of money. And if they are costing you a lot of money, they're already on your plan. Trust me. So, so these are things that, again, you don't have to live in the box. There's no limit to the number of plan options you can offer. Now, again, I'm not saying if you have a 50 life company, you need to go offer 20 options. That's just ridiculous. But at the same time, you don't need to think that it has to be one size fits all, or here's how it has to work. It is your benefit plan. Benefit being the key word. What will benefit your employees? Go create it. Remember, you can create anything you want. From a compliance perspective, there's two key things. One is don't discriminate. And 2, make sure you have an option that checks all the boxes of the Affordable Care Act. Beyond that, you can do whatever you want. So again, as long as you have that, from a compliance perspective, you're fine. The second thing is then now go find somebody that's willing to administer it. And you know what? Most people, or there's almost always an option to have anything administered you want administered, because administrators, they like to get paid. And if you want to pay them to administer your plan, you can do that. And so that is the beauty of this. And I think that is the big thing, Phil, that I see so often when we're talking to employers is they can't get out of this box of this is the way we've always done it. The other thing that I'll say that you need to think about is don't do things rashly and don't do things without data. Now, that doesn't necessarily mean claims data, because I recognize a lot of employers don't get claims data. Although if you do, you need to certainly build something around that. But data can be what I mentioned earlier, asking your employees, looking at benchmarking data around your industry, around your geographic region, what hospital systems are in your area, what contracts work best, what network is going to be the best, which one can you utilize these things for. These are all data sets that will allow you to make a wise decision. We tell people emphatically to make strategic plan design changes, you need at least 6 months to do it right. You need at least 6 months because, one, you got to make sure that you can find all the pieces to do what you want. Well, first you got to gather the data. Then you got to find all the pieces and kind of create the strategy off of that. Then you got to educate. You want your employees to understand how to use it. And you don't want to do that initial education in an open enrollment meeting. That's a really bad time to roll things out, right? You want the open enrollment meeting to be, hey, for the last few months we've been telling you about this, just solidifying it, right? These are the important things to consider when you're making a decision around plan design. So first, know that you have control. 2, give yourself enough time. 3, utilize data to make your decisions. 4, make sure you got the right pieces of the puzzles to put it all together, i.e. administrator, reinsurer, all of that. And then finally, give yourself enough time to educate on it. Make sure your people understand the value of it. Because if they do, they will perceive it as a benefit. And you can do what we talk about all the time, which is you can improve benefits while simultaneously reducing costs. It's a win-win across the board, and it can certainly be done.
Yeah, thanks for that, Seth. And one follow-up question to something that you had mentioned in there, and then we'll kind of open it up to questions, and then we can wrap up. Was you talked about, talking to your employees, and after talking to many prospective clients, and one question that we always like to ask is, when was the last time you administered an employee survey? And shockingly enough, many times we hear that it's been years or they've never administered an employee survey. Can you kind of talk about the importance of that, how often we like to try to do those, and also can maybe touch on, if you have a rough estimate on how many employers are actually administering those, just kind of dive into that just a little bit, because we realize how important it is. So just maybe touch on that just a little bit.
Yeah, I don't know how many employers, Phil, are actually doing it. My assumption, just based on conversations that we've had with employers, is very few, and most of them are doing it wrong. And what I mean by that is they're not doing it with the intentionality of leading the horse to water. And I know that sounds counter. You're like, well, wait a minute. I want to know what my employees think. No, you don't. No, you really don't. You want to know what your employees think about something specific. So if you just said, I want to know what my employees think, well, you're asking too many broad questions and you're not going to ever get to the heart of the issue. You need to be intentional about your questions that you're asking. You need to keep a few questions. Don't do a long survey, right? And you need to give them optional answers. You can certainly give them the ability to give you their own answer. And you also need to not be fearful of the results. But again, it's critical that the more intentional you are with how you're asking the question, the more that you're going to gain a result that's going to help you do what it is you're trying to set out to do. The less intentional, the more you're going to get a whole bunch of noise. It's funny, we were talking, I think, Phil, recently with an employer. They said, I'm terrified to hear what the employees might say. Okay. Well, that just means they're talking behind your back because they're saying it. So why not get rid of that fear, but recognize that you're going to be able to guide them. A lot of times your employees think the way they do because of a lack of understanding, right? They think, oh, well, this is the way it is so the company can make more money, or, oh, this is only serving the executive team, or, whatever. The more engagement you can get with your employees on that, and the more they feel like they're part of it, the better the outcomes are going to be. The more they'll adopt the idea of it, and the more you can utilize your message. I tell employers all the time, a survey is almost as equally as important as to utilize as a tool for you to get your message out there as it is to get your feedback from your employees if you do them right. So that is the critical piece here, right? You should be doing them. I tell people I would encourage at least once a year, right? You don't want overkill. If you've never done one, maybe every other year to start out. You certainly don't want to start doing it every quarter. You don't want to put the suggestion box at the front of the office. I'm not looking for your suggestions. I'm looking for your thoughts based on the parameters that I've just set forth to get your thought. And so that's certainly something to consider there. But, your employees will tell you what they're really wanting in the silo of how you're wanting them to respond, so long as you create the avenue for them to do it in a way that is in that silo. And when you do that, everybody walks away, most people, I should say, walk away with good information and a good firm step forward.
Yeah, thanks for answering that and kind of diving into the surveys a little bit, because we do believe that's an extremely important piece. Understanding what your employees want and what their needs are, because obviously, as we mentioned at the beginning, how do we remove barriers within plan designs to help employees understand how to best utilize their health insurance? So if anyone has any questions, we'll kind of open it up for questions here. Feel free to type them into the chat box, or you can unmute yourself at the bottom of the screen. We'll stay on here for as long as we have questions. If not, we'll probably wrap up here in about 5 minutes, but I did want to kind of open it up for questions here. And also, I did want to mention too, if there's any questions that you think of after this, or anything you want to learn more about that we talked about today, feel free to reach out to myself or any of the other risk advisors that we have on the call today. We'll be more than happy to answer your questions. Oh, we did get some questions here, Seth. So first one, what are questions an employer may ask to verify the deductible is structured to be most affordable for the employees?
I'm assuming you're specifically asking around a survey question. One question would be, asking specifically, give them a range of how much could your family afford in a medical catastrophe or situation like that. Again, you got to be careful with that question a little bit, because everybody's probably going to default to the lowest number because they think that may be why you're asking that question. Typically I won't go down deductibles in a very direct question from a perspective of what kind of deductible do you want? Well, guess what? They're all going to want zero. They're all going to want the lowest cost. Instead, you might pose it around, would you prefer an annual deductible of a set amount, or a lower deductible that resets on a monthly basis, right? And that's going to give you insights into someone who might think, okay, I may have a lot of procedures or just one. And here's where I'm going with that is, so again, if you think about a deductible, most employees don't have more than one procedure a year, if they have one at all. And from an underwriting perspective, if I have one $3,000 deductible or a $500 monthly resetting deductible, I'm actually going to give more credit in a rating structure to the $500 resetting deductible than I am to the one-time $3,000. Now, mind you what I just said. For a one-time $3,000 deductible, I would have to have 6 months of procedures at $500 or more. Doesn't happen very often, right? But what I've just done is allowed an employee to say, we have a $500 deductible. It resets monthly. We have a $500 deductible. So if you have anything major happen, you're effectively just going to have one deductible of $500, right? But give them those types of questions to say, okay, where would you rather be? And then ask questions around if there was a single, limited options for you to get imaging and labs and things like that done at a copay as opposed to a deductible, or a deductible where you could go anywhere. Which would you prefer? These are some of the things you can do. I tell people though, when you're setting your actual deductible, it really is, and I know it's hard because we've been trained for the last 30 years to think that it is the end all be all. It's really not. Two key metrics are the most important in your plan. Your out-of-pocket maximum, okay, and how you're structuring your network access to reduce costs. So if you want a $500 deductible, that's fine. Put a $500, put a $200 deductible in there for all I care. You can adjust your co-insurance and your out-of-pocket maximum to make sure the employee's engaged at a higher level. And then you can provide narrower options within the broad network to drive them to lower cost places. Because if they're paying a co-insurance, trust me, they're going to want to make sure that they go to the places that have the lower co-insurance level. The deductible is misdirection from the insurance company. That's it. Don't let that be your barrier.
Yeah, thanks for answering that, Seth, and thanks for that question, Molly. Let us know if you have any other follow-up questions to that. We did have another question from Kevin. He asked, by adding varying coverage layers to the benefit plan, does it necessitate the use of a concierge service, for example, Quantum, Health Joy, to help employees identify their low-cost options and navigate the plan?
Yeah, it certainly does help with those types of resources in place. Something that helps the employees to guide them. Regardless, you need a tool that's going to allow employees to recognize which ones are the lower cost providers, right? The last thing you want is them to show up to only find out that maybe the one that they showed up to was the higher cost. So there needs to be a tool, right? There's a lot of tools, right? You've got directories. Employees by and large won't use them, but there are low-cost tools that are out there, whether that be app-based, telephonic-based. We've actually had employers sometime that have gone into requiring a pre-authorization or a pre-call into the case management team or something of that sort. So there's a lot of options there, but yeah, to that point, I always recommend that there's some type of concierge service there or some type of transparency. By the way, these are you can get these relatively inexpensive, and the costs associated with them built into your plan. Sometimes the TPAs can do them, but you need something built into the plan that is going to be massively offset any cost there to your upside by tiering out the network.
Yeah, thanks, Kevin, for that question. Again, if any other questions come from that, or you want any other clarification, feel free to reach out. And then our last question we have here, Seth, was from Deb, and she asked, is there any options for someone with pre-existing conditions other than Obamacare, which is not affordable?
I'm assuming Deb's talking about the individual market. I mean, there really are few options, unfortunately. There are plans out there that are like MediShare plans. You'll hear commercials for them quite often. The challenge is most of those will have some underwriting components. The only two avenues with no underwriting and waiver of any pre-existing condition clauses are going to be the employer market or plans that are approved by the Affordable Care Act. Those are really the only two, to my knowledge, that are out there, unfortunately.
Yeah, thanks for answering that, Seth. That's the last question that we had come through the chat box. We'll stay on here for a couple more minutes if anyone has any questions. If you do not, feel free to jump off. We do appreciate everyone tuning in today. stay tuned for our next roundtable that will probably be here in the next, I would say, 8 weeks. Once we get that scheduled, we'll start shooting out invites for those. And again, as I mentioned, if you have any questions that come up or want to learn a little bit more about anything that we talked about today, feel free to reach out to myself or any of the other risk advisors, and we'll be more than happy to answer those questions or get you more information.